So we're back on the everyday ultrasound. We've just got someone come in with a very sore knee, bad osteoarthritis of the knee, can barely walk, waking at night. It's like a very common thing, of course, for GPs, isn't it? We do this all the time. And so we're going to we see this all the time, we're going to put a steroid injection in. And so just putting some betadine on. We'll have a little look around the knee on the screen. You can do these blind, like we all trained doing these anatomically back in the day, these knee injections, and most of the time seems to work okay. But it's pretty nice to have a really clear picture and to be sure that you're going in, right in the right spot. And the more you scan, the more you realise the potential for injecting in the wrong areas. So I'll show you a bit today what we have. I use a sterile gel for these things, but you don't necessarily have to, as long as you don't put your needle through unsterile gel. Let's have a quick look on the screen and we'll just get up really close to see. Okay. Yeah. So let's have a look. So that's just a longitudinal view of the knee. There's the kneecap there, and there's the quads there, and underneath the quads you can see an effusion, which you often have with these people with arthritic, really painful knees, and that's a bit of synovium within the effusion. So that's the longitudinal view. You can see the effusion tracks up quite a bit, and that's all continuous with the knee joint, of course, if we kept on going down. So we're back on that's the kneecap. So then we turn transverse, and we're sort of looking at there's the kneecap there, going a bit sort of distal. And there's the effusion in there. So we're going to aim for a spot in there where we think we can hit a fluid pocket and just pop our injection in there. So going to be a little sting in the skin. So just a little sting, okay? Sakit. Little sting. Sorry. Aduh. Well done. So there's a needle coming in from the right hand side of the screen. And we just sort of push towards that. Yeah, well done, doing great. A bit uncomfortable going through the synovium there, and you can see we're in that area, so I'm just injecting there. Just trying to keep there we go. You can see it injecting into the effusion there. A little bit of swirling of gas bubbles and things. Nearly finished. So just a bit of depot-medrol with some local. And that's it. And then we just sort of come out. Abis, Sudabis. So that's very quick doing that. I'm just going to move your knee a little bit just to just up and down, up and down. This is just to spread the fluid. That's good, yeah. And of course sometimes people get comfortable pretty quick just from the local. Yeah. So find your biggest pocket of fluid. Doesn't matter if it's medial, lateral, superior to the kneecap, and the suprapatellar bursa there, and pop it straight in. It's more difficult, a little more difficult when there's no effusion at all, but that's for another day. Thanks very much for watching.